Welcome back to the Deep Dive. Today we're tackling a topic that comes up constantly in healthcare, hypertension.
High blood pressure.
Exactly. It is probably the single most common reason people see a doctor, yet the actual mechanics behind it are incredibly complex.
They really are.
So we've taken that stack of source material you shared with us, and our mission today is to really build a map of what's happening inside the body when that pressure starts to creep up.
And it's so important that we do. I mean, the sources really hammer this home. High blood pressure isn't just a number on a cuff. It's a massive preventable risk factor for a whole range of terrible outcomes.
Things like stroke, heart disease.
Right, both ischemic and hemorrhagic stroke, coronary heart disease, heart failure, chronic kidney disease, the list goes on. Even some forms of dementia.
The scale of it is just staggering. I was shocked by one of the stats in the materials. It said high blood pressure is a component in more than a third of all office visits by adults in the U.S.
And that's just the U.S. It's a global problem. And what's really, I think, the core issue the sources point out is that this is a hugely preventable burden.
Right.
Prevention is the best route, but it's poorly implemented. And even when we do diagnose it, treatment and control are, well, they're often not where they need to be.
Which is why we need to understand the fundamentals.
Yeah.
So let's start there. Let's start with the basic physics of it. What are the two big variables that determine our blood pressure?
It's actually a pretty simple equation when you boil it down.
Okay.
Arterial blood pressure is determined by just two things. First, cardiac output.
Which is how much blood the heart is actually pumping out.
Precisely. It's your heart rate times the amount of blood pushed with each beat. This is the big player in, acute responses.
Like when you get startled or run for a bus.
Exactly.
Yeah.
That immediate spike is your cardiac output jumping. The other half of that equation is peripheral resistance.
So how much the pipes are squeezing back?
That's a perfect way to put it. It's the constriction in the small arteries and arterioles. If they tighten up, resistance goes up and the pressure has to rise.
Okay, so output and resistance. But the sources were really clear that this simple math isn't the whole story, especially for long-term pressure.
No, it's not. And this is a really key insight. While that equation is great for moment-to-moment changes, our blood pressure over the long-haul months, years, is largely controlled by a much slower system.
And what's that called?
The sources refer to it as the renal volume endocrine pressure control system.
That's a mouthful.
It is, but it's the master controller. It works slowly to adjust your total blood volume and that overall peripheral resistance. It sets the baseline.
So if that system is the long-term thermostat, then the vessels themselves must be incredibly active participants.
Oh, absolutely. Which brings us to one of the most fascinating players in this whole story, the endothelium.
The inner lining of the blood vessels. We hear that term a lot. What is it actually doing?
Well, first, it's not just a passive lining like in a plastic pipe. It's a single layer of cells, and it's a chemical powerhouse. It is constantly monitoring blood flow and regulating the tone of the vessel.
So it's sending out chemical signals.
Constantly. It's releasing both relaxing factors and contracting factors.
Okay, so give me an example.
For relaxing, the big one is nitric oxide. It's a powerful signal that tells the vessel to widen, to dilate, but at the same time, the endothelium can also release things that cause constriction, like peptides called endothelin.
So it's playing both sides.
It has to. It's maintaining that delicate balance, and this is so critical. The sources suggest that endothelial dysfunction, when that lining gets damaged and stops working properly, might be a key factor in starting or accelerating both hypertension and atherosclerosis.
The smart lining goes offline,
Yeah.
and the system starts to fail.
That's it, exactly.
So beyond that local control, you have these bigger body-wide systems. The hormones, the nerves.
Yep, the ones that orchestrate this whole tug of war. You have systems that are basically screaming constrict and retain.
And what are they?
That's primarily the sympathetic nervous system, your fight or flight response, and crucially, the RAAS.
The renin-angiotensin-aldosterone system.
That's the one. It is the body's emergency system for holding on to salt and water, and it powerfully drives up resistance.
And then you have systems on the other side whispering, relax, let it go.
Right. Counterbalancing the RAAS, you have things like the bradykinin system and natriuretic peptides. They promote vasodilation and excretion. It's a constant push and pull.
So if we follow this thread, this idea of retaining fluid and salt, it seems to lead us directly to one organ in particular.
It does. We land right at the kidney.
The sources really frame the kidney as the ultimate long-term controller of blood pressure. Why is it so central to this story?
It all comes down to its obsession with one thing: Sodium balance.
Salt.
Salt. This goes back to a foundational concept from the 1960s called the Guyton hypothesis.
Okay, what did Guyton propose?
Arthur Guyton's big idea was that at the end of the day, your long-term blood pressure level is dictated by the kidney's ability to excrete sodium. If your kidneys are slow to get rid of salt, your pressure has to go up to force it out.
Wow. So that reframes high blood pressure, at least in many cases, as a salt handling problem more than a heart problem.
In the long term, yes. And this mechanism has a name. It's called the pressure natriuresis phenomenon.
Break that down for us.
Natriuresis just means excreting sodium in the urine. The pressure part means that as your arterial pressure rises, the kidney responds by excreting more sodium.
So wait, the body raises its own blood pressure on purpose just to push salt out through the kidneys?
That is the perfect way to think about it. It's a trade-off. The body prioritizes keeping sodium levels stable, and it's willing to accept a higher blood pressure to achieve that goal.
But that seems destructive. Why would it do that?
It's an evolutionary thing. We evolved in environments where salt was scarce. Our bodies are exquisitely designed to hold on to sodium to prevent dehydration. That RAAS system is a survival tool.
Ah, I see. So a system designed for a world of scarcity is now backfiring in our modern world
Of processed foods and high-salt diets, exactly. Our ancient physiology is now working against us.
And the sources say this leads to a vicious cycle for some people.
It does. Here's the key consequence. If you have an impaired ability to excrete sodium, if your kidneys are just a bit sluggish for genetic or other reasons, you need a greater increase in your blood pressure to get rid of the same amount of salt.
Your baseline pressure just has to live at a higher level to keep things in balance.
Precisely. The system finds a new, higher set point, and that becomes your chronic hypertension.
That's an incredible insight. Okay, so now we have a map. We have cardiac output. We have peripheral resistance from the endothelium. We have the hormonal RAS system. And we have the kidney's master control over sodium.
Those are the targets.
So how do our modern medicines actually hit those targets?
It's really elegant, actually. The different classes of drugs are designed to intervene at almost every point we just discussed.
Okay, let's start with the most direct approach. Just forcing the pipes to relax.
Those are the vasodilators. The classic example is calcium channel blockers, or CCBs. They interfere with the calcium that muscle cells in the artery walls need to contract.
No calcium, no squeeze.
No squeeze. The vessel relaxes, resistance drops, and pressure comes down. Simple as that.
All right, what about that big hormonal system, the RAS?
This is where some of the most widely used drugs live. The RAAS blockers. They're all about stopping that cascade that leads to vasoconstriction and sodium retention.
Like ACE inhibitors.
Exactly. ACE inhibitors, or ACEIs, block the enzyme that creates the really potent hormone, angiotensin II. Then you have ARBs, which block the receptors where angiotensin II would attach.
They block the message from ever being received.
Right. And then renin inhibitors block the process even earlier. They all attack that same pathway.
And the sources had that really interesting detail about a specific side effect of ACE inhibitors.
Oh, yes, with bradykinin. It's a fantastic example of how interconnected this all is. The ACE enzyme doesn't just create angiotensin II, it also breaks down a vasodilator called bradykinin.
Okay.
So when you inhibit that enzyme with an ACEI, you get a buildup of this relaxing substance, bradykinin.
Which is good for blood pressure.
It is, but in some people, it can cause a persistent dry cough or, rarely, a type of swelling called angioedema, a side effect caused by boosting a helpful substance too much.
Fascinating. Okay, moving on. What about calming down that fight-or-flight response?
For that, we use sympathetic blockers, most commonly beta blockers.
And what are they blocking?
They antagonize neurotransmitters like epinephrine. They basically tell the heart to slow down and not beat so forcefully, which directly lowers that cardiac output part of our original equation.
Okay, that covers the heart, which leaves us with the kidney, the diuretics.
The diuretics, which focus squarely on sodium and fluid. The main ones for long-term use are the thiazides.
And how do they work?
They work in a part of the kidney called the distal convoluted tubule to increase sodium excretion. But here's the really interesting part the sources highlight.
Go on.
While they start by reducing your blood volume, their long-term blood pressure lowering effect actually comes from reducing peripheral arteriolar resistance.
So they start off as a volume drug, but morph into a resistance drug over time.
Exactly right. Then you have the more powerful loop diuretics. They work higher up in the kidney, in the loop of Henle, and cause a much more dramatic, rapid loss of sodium and water.
So they're not for everyday management.
Generally not. They're more for acute situations like managing fluid overload and heart failure. Potent but short-acting.
And finally, you can target that last hormone in the RAAS chain, aldosterone.
Yes, with drugs called mineralocorticoid receptor antagonists, or MRAs. They block aldosterone from telling the kidneys to hold on to salt and water. It's the final stop sign in that whole RAAS pathway.
So when you put it all together, it's really a multi-pronged attack on a very complex system.
It has to be. Blood pressure control is this delicate negotiation between the heart's pumping, the resistance in the arterioles, and the kidney's slow, steady management of sodium.
Okay, we've laid the groundwork for the biology. Now we have to shift gears to the practical, crucial, but often botched starting point: blood pressure measurement. Our sources were extremely clear that even though this is the most common procedure in medicine, accuracy issues are just rampant. We are now moving into the crucial starting point: blood pressure measurement. This section is designed to be the 1-minute synthesis of the core facts.
Okay, so measurements are the single point of failure or success. They estimate your true average BP, predict your cardiovascular disease risk, and crucially, they determine if and when you start treatment. But the errors are rampant. The medical literature notes that, on average, office systolic BP is often overestimated by about 7 millimilliHGs.
And 7 millimeters of mercury might sound trivial, but that systematic error leads to a 15 to 20% overestimation of hypertension prevalence in the population. That is millions of people who might be wrongly labeled or treated unnecessarily.
Conversely, failing to follow the protocol can also lead to underestimation and misdiagnoses. Since these clinical errors are so common and so unpredictable, the only solution, as stressed by all major guidelines, is adhering strictly to a standardized measurement protocol.
Yes, and almost no one follows it. Patients need to avoid caffeine, smoking, exercise, all for at least 30 minutes before the measurement.
And the first rule on the list, which I love, is don't have a full bladder.
Oh, yes.
I feel like that could solve half the problems in a clinic visit.
It's all about relaxing the body, getting it to a baseline,
Yeah.
and the position checklist is just as important.
Okay, what's on that one?
You need to be resting quietly for, say, 3 to 5 minutes.
Okay.
Seated, with your back supported, feet flat on the floor. And the cuff itself, it has to be the right size, has to be supported at heart level.
So if you're talking on your phone or just kind of sitting awkwardly on the exam table.
The reading is compromised. It's just not accurate.
And then there's the protocol itself. I think this is where a lot of clinics fall short.
They often do.
Ah.
You absolutely need a clinically validated, preferably automated device. But here's the real kicker.
What's that?
Your true usual blood pressure isn't one reading. It's an average of 2 or more readings, taken across 2 or more separate visits.
So that single number from last week's checkup, it's really just the very, very beginning of the story.
Exactly. Which brings us to the really dangerous part. The part where the office measurement can sometimes, well, lie.
Because it's such a limited and often high-stress environment.
Precisely. Guidelines now routinely recommend you have to complement office readings with out-of-office ones to really confirm a diagnosis.
And this is where we get into 2 really common conditions. I was surprised to see they each affect something like 15 to 25% of people.
They're very common.
First up is white coat hypertension.
Right. This is when your office blood pressure is high, but when you measure it at home, it's perfectly normal.
So what's the good news there?
The good news is your long-term cardiovascular risk is lower. And treatment might just be lifestyle changes, not necessarily medication.
Okay, but then there's the flip side of that coin, masked hypertension.
And this one is much more worrying. This is where your office BP looks great, totally normal, but your readings outside the office are consistently high.
Wait, so someone could be told they're fine, but they're actually at the same risk level as someone with diagnosed sustained hypertension.
That's it. It is a huge, huge miss in clinical practice. We usually suspect it if we see other signs, like end organ damage.
Like the heart muscle thickening. Left ventricular hypertrophy.
Exactly, which is why we have to get the measurement out of the clinic.
So home blood pressure monitoring.
It's the most practical approach.
Yeah.
You get a validated device and you follow the same standards, resting, proper position, and take an average of morning and evening readings.
And the threshold is the same, 130 over 80 for hypertension.
Yes, 130 over 80 for both office and home.
Just to anchor us, that's systolic over diastolic, right? The pressure when the heart beats versus when it's resting.
Are correct.
So if home monitoring is so practical, why would anyone do the more expensive, intrusive ambulatory BP monitoring?
Because that 24-hour cuff gives us the deepest insight, especially into what happens at night. Your nighttime blood pressure reading. That might be the single best predictor of your cardiovascular risk.
Wow. And what you're looking for specifically is this non-dipping phenomenon.
Non-dipping, yes. That's when your blood pressure fails to take that normal pronounced dip while you're sleeping.
And that's a serious risk factor.
A powerful one. And it's also worth noting that BP non-dipping is significantly more common in non-Hispanic blacks.
So for anyone listening in that group, this isn't just a clinical curiosity. It might be essential for an accurate diagnosis.
Absolutely essential. For reference, the ambulatory thresholds are 130/80 during the day, but at night, it's much tighter, 110/65. Okay, so you've done it right. You have your readings from different visits, you've averaged them, but now you have two numbers, systolic and diastolic, and they often don't agree.
Yeah, that happens all the time.
Your systolic, the top number, might scream stage 1 hypertension, but your diastolic, the bottom number, is perfectly normal. Which one wins?
That's the tiebreaker rule, and it is crystal clear.
Yeah.
You always go with the higher classification.
Always the higher one.
Always. The system is designed to identify the highest level of risk. So if one of your numbers puts you in stage 1, then your classification is stage 1. It doesn't matter how good the other number looks.
You're only as healthy as your weakest link, basically. Okay, so that framework, multiple readings, multiple visits, highest category wins, that sets the stage. Now let's get into the nuts and bolts, the actual numbers.
Let's do it.
We'll start in the safe zone. Normal blood pressure. This one has a strict rule. It's a logical AND. Your systolic has to be less than 120 AND. Your diastolic has to be less than 80.
Both have to be in the zone. If either one is out, you're not classified as normal.
Right. And that AND rule carries over to the next category up, which is elevated blood pressure. Here, your systolic creeps up into that 120 to 129 range.
But, and this is what trips people up, your diastolic must still be less than 80.
So that DBP under 80 is like a firewall for both of those first two categories.
Exactly. The second your diastolic hits 80, you are out of the normal and elevated categories, period, regardless of what your systolic is.
Okay, but this is where the whole logic flips, right?
Yeah.
Because once you cross into a hypertension diagnosis, the rules change completely.
It's a profound shift. We go from AND to OR. And that makes getting the diagnosis a lot easier because you only need one number to cross the line.
So what's the first line you can cross? Stage 1 hypertension.
Stage 1 is a systolic between 130 and 139 OR, a diastolic between 80 and 89.
Just one or the other.
One or the other. A systolic of 132, you're stage 1. A diastolic of 85, you're also stage 1.
And then the next level, stage 2 hypertension, it follows that same OR logic.
Same exact logic, just higher numbers. A systolic of 140 or more, or a diastolic of 90 or more. Cross either of those lines, that's stage 2.
We all sort of assume blood pressure goes up with age, but the evidence strongly suggests that this increase we see, it's actually not a biological necessity.
That's it. That's the essential insight for this whole deep dive, really. It changes everything. But, before we jump into the figures, it's important to remember that diagnosing hypertension is, it's complicated. The numbers depend a lot on the criteria being used for that specific population.
Okay, so let's unpack that common age pattern first.
Mm-hmm.
Usually we see the top number, the systolic BP, just keep on climbing.
Progressively, yeah.
Especially when people get into their 70s and 80s. But the bottom number, the diastolic, that's a different story.
Yeah.
It plateaus, right?
It does. It increases less steeply until about middle age, and then it just sort of levels off or even starts to decline.
Which creates that widening gap, the isolated systolic hypertension that you hear about in older adults.
Exactly. And this ties into another concept the sources bring up, which is tracking.
Right.
It's this idea that, if you have relatively high or low blood pressure when you're young, you tend to stay in that same track later in life. It's a crude predictor, but it's there.
And that brings us right back to the big paradox. The sources are clear on this. In some isolated populations around the world, there's little or no age-related change in blood pressure.
None whatsoever.
And that's the absolute proof, isn't it? It proves high blood pressure is not just a mandatory part of aging.
It validates the whole idea of prevention. If it's not mandated by biology, then the focus has to shift. It has to be about environmental causes.
So where's the best evidence for that?
The most crucial evidence comes from the migrant studies. They are fascinating. They followed people who moved from their native isolated setting to a more modern non-native one.
And what happened?
The results were uniform. They all started to show that common age-related increase in blood pressure.
So just changing your environment fundamentally changes your biology. That really reframes the word inevitable.
It does.
So what are those specific lifestyle changes? I assume it's the usual suspects.
It's a whole package deal,
Yeah.
tied to westernization, but the sources point again and again to increases in dietary sodium.
And a drop in potassium at the same time.
Exactly. And then you have less healthy diets overall, a big drop in physical activity, and then, of course, weight gain and more alcohol.
Okay, so let's shift gears. Who is this affecting right now? Let's start with the U.S. The prevalence is around 46% of adults. It's pretty stable, but that's still over 103 million people.
It is, but that age gradient is just so intense. You see it jump from, 20 to 30% in young adults?
To a staggering 80, even 85% in people over 75.
Yeah. And what really stands out in the U.S. data are the significant racial and ethnic disparities.
That was a big point in the sources.
A huge point. Non-Hispanic Black adults have a much higher rate of prevalence. We're talking 59%.
59. Wow. Compared to about 45% for whites and around 46 or 47% for Asians and Hispanics.
And it's not just the higher rate. It tends to start younger in that group, and it leads to more severe cardiovascular and kidney problems down the line.
The sources also mentioned a kind of a geographical variance.
That's right. The southeastern U.S. has a higher prevalence and more complications like stroke compared to the Northwest.
And what does the global map look like?
Globally, it's a bit of a tale of two worlds. The prevalence is actually increasing in low and middle income countries. It hit over 1 billion people in 2010.
1 billion. And in high-income countries.
There, it's actually showing a slight decline.
And for anyone facing this, the number on that blood pressure cuff is really just the start. Our mission here is to get into the hidden numbers, the diagnostic tests that fundamentally change the entire conversation about your health and your treatment. The thing is, this initial workup isn't just busy work. The forces are pretty clear that the basic lab tests have to answer 5 key questions.
Exactly. You're looking for existing organ damage, for one.
Right.
And you're also hunting for secondary causes, like a hormone issue or, other conditions that often come along for the ride, like diabetes.
And all that data helps you pick the right drug, I assume.
It does. And to get those answers, there's a core set of tests you should really expect. We need a complete blood count, a full lipid profile, and something to check your blood sugar status, usually at HbA1c.
Okay.
We also look at electrolytes, so sodium, potassium, calcium. That potassium level is especially key. If it's low, it might point toward a secondary cause, like primary aldosteronism.
So it's like a clue.
It's a huge clue.
Yeah.
Then, of course, we have to assess the kidneys. We look at serum creatinine and calculate the estimated GFR.
GFR, that's the glomerular filtration rate.
Yep. It's just a measure of how well your kidneys are cleaning your blood. We pair that with a urinalysis and the urine albumin to creatinine ratio.
And there are a couple more, right?
Just a couple. A TSH level for your thyroid, and critically, a 12-lead ECG for the heart.
That's a lot of data points, but I think it's important to mention a point the guidelines really stress.
Oh, for sure.
If you're in a setting where you can't get this full panel of tests, that should absolutely not stop a doctor from starting treatment to lower your blood pressure.
No, never. Getting the pressure down is priority 1. A full workup is the ideal, not a barrier.
So once we have all this data, how does it all come together? That brings us to risk stratification. And here's where it gets really interesting. The sources say that CVD risk doesn't just, switch on at a certain number. It's a continuous line, starting from a systolic pressure as low as 90.
That's the part that's so fascinating. Because at any single blood pressure level, let's say 135, your 10-year risk for a heart attack or stroke can vary by more than 30-fold.
30-fold. Wow.
Yeah. It all depends on what else is going on. Is that blood pressure reading an isolated issue, or does it have, 3 or 4 other risk factors along with it?
And that makes a huge difference in treatment.
A massive difference. So take someone with stage 1 hypertension. Their top number is, say, between 130 and 139. If that's their only risk factor, their absolute risk is pretty small. Drug therapy might not seem that urgent.
But if they have other issues.
But if that same person has high cholesterol and maybe their kidney function isn't great, suddenly their absolute risk is high, and the benefit of starting a medication is much, much greater.
And to make that calculation, for a long time we've used the ACCC age-pooled cohort equations.
Yeah.
That was the standard for adults 40 to 75.
It was. And a high risk there was defined as a 10-year risk of 10% or more. But that model is well, it's evolving.
Okay, so what's replacing it?
We're now seeing the rollout of a newer model called Prevent. If the old one was a paper map, Prevent is like a fully integrated GPS.
I like that analogy.
It's for a wider age range, 30 to 70, and it predicts both 10 and 30-year risk. But the crucial part is what it adds. It pulls in actual kidney function data, like that urine albumin ratio we mentioned.
It adds something else pretty new, doesn't it?
It does. For the first time, it brings in social determinants of health, basically using your zip code as a proxy. Plus, it can specifically predict your risk for heart failure, which is a huge complication of hypertension.
Okay, so let's unpack primary puzzle first. Doctors often call it essential hypertension. And the definition is, well, it's simple, but it's crucial. There's no single obvious underlying cause.
Exactly. And while the sources confirm there's a heritable component, adoption and twin studies definitely support that. The connection isn't simple. We're not talking about a single blood pressure gene.
So it's more complicated.
It's what we call polygenic. It means many different genes, each one contributing just a very small, modest risk.
It's a practical application for you, the listener, in a clinic right now?
It's still very limited. It really means that even if genetics sort of load the gun, the environment is almost always what pulls the trigger.
Let's talk about those triggers then.
Yeah.
Starting with some surprising ones, general environmental exposures. I was genuinely surprised to see heavy metals listed so prominently.
Yes, things like lead, mercury, cadmium, arsenic. The research points to strong associations. These are often chronic, low-level exposures that over time can contribute to vascular damage and higher blood pressure. It's a quiet hazard.
And then there's the air we breathe. Air pollution, specifically that particulate matter, PM 2.5, is also strongly associated with higher BP. That's just a fact of modern life for so many of us.
What's really fascinating is that we can actually quantify the impact. The studies commonly cite an increase in systolic blood pressure. That's a top number of around 3 to 5 millimeters of mercury.
3 to 5 doesn't sound like a massive number on its own.
It doesn't, but when you consider that a population-wide shift of just 2 mmHg can drastically reduce rates of stroke and heart attack,
then that number is absolutely not negligible.
Not at all. The mechanism is probably a few things. When you breathe in these particles, they cause this chronic low-grade inflammation. They can also directly affect the lining of your blood vessels, the endothelium, making them stiffer, less able to relax.
And that drives up pressure.
That's right.
Beyond pollution, what about geography and climate? I always notice my own BP seems a bit lower in the summer. Is that a real thing?
Oh, it is. Blood pressure tends to be lower during the warmest seasons and measurably higher in the coldest. Your body constricts blood vessels to conserve heat when it's cold, and that increases pressure. And for anyone who's a hiker or mountaineer, high-altitude exposure also tends to raise BP, likely from the combination of low oxygen hypoxia and the cold.
So we've got these broad environmental pressures. But then the sources really zero in on what they call the 6 highly prevalent personal exposures.
Yes.
And these are the factors that are responsible for most of the age-related BP increases we see around the world. This list is basically the blueprint for lifestyle management.
It absolutely is. And factor number 1, maybe the most complex, is diet quality. And within that, the relationship between sodium and potassium is, well, it's paramount.
Let's pause on potassium for a second. Everyone jumps to cutting salt, but the sources really emphasize that not getting enough potassium is a standalone risk factor, specifically for stroke.
It's a critical point. Potassium helps balance sodium's effects and is crucial for healthy nerve and muscle function, including the heart. The problem is it's almost universal.
How so?
Almost all adults worldwide get too much sodium and, at the same time, fail to meet recommended potassium levels. We've been so focused on taking things out of our diet, we've forgotten about what we need to put in.
That dual failure really captures the modern diet, doesn't it? Too much salt, not enough potassium.
It does.
Okay, moving on. We hit body weight, and the statistic here from the U.S. is just staggering.
It is. Roughly 3/4 of U.S. adults are classified as either overweight or obese. When you have that much extra body mass, the heart has to work harder, blood volume increases, and it drives hormonal changes that all push BP up.
I mean, that statistic is just staggering. It makes primary hypertension feel less like a medical problem and more like a massive societal one.
It fundamentally changes the dynamic, and it links directly to the next factor, physical inactivity.
Right.
The data suggests that over 1/4 of U.S. adults report no activity outside of work, and about half report getting less than the recommended 150 minutes of moderate aerobic exercise a week.
And what's the mechanism there? I mean, beyond just burning calories, how does exercise actually help our blood vessels?
Aerobic exercise causes your body to release natural vasodilators. These are compounds that tell your blood vessels to relax and open up. It directly improves that endothelial function we mentioned, so your arteries are better at managing blood flow.
So if you're sedentary, you just lose that conditioning.
You lose that natural ability to relax the vessels.
The last two on the list are alcohol and stress. Both are highly prevalent. For alcohol, 85% of U.S. adults report drinking, and a quarter report binge drinking in the last month.
And stress is that quiet, chronic driver. Both alcohol and stress directly activate the sympathetic nervous system. That's your fight or flight response, which tightens blood vessels and speeds up the heart.
So to sum up this first part, primary hypertension is really the battle of prevalence.
Yeah.
It's driven by these 6 personal exposures, which is why lifestyle is always the foundation of treatment.
Precisely. Now, let's pivot. Let's switch hard to the minority of cases, part 2. Secondary hypertension.
Okay.
This is where we shift from managing a lifestyle pattern to doing some real diagnostic detective work. We're looking for a specific, overt anatomical or biochemical cause.
What are the red flags?
The sources outline 4 critical indicators. First is treatment-resistant hypertension. That means BP is still high, even though you're on 3 or more different kinds of blood pressure drugs.
Okay, that's a big one.
Second, an abrupt worsening of hypertension that was previously under control. Third is disproportionate target organ damage. So, for example, severe kidney damage when the BP reading is only mildly high.
And the fourth indicator?
Specific lab findings. Things like unprovoked hypokalemia, low potassium levels that aren't explained by diuretics or something obvious or protein in the urine.
Got it. And among all these secondary causes, there's one that's way more common than the rest. Obstructive sleep apnea, OSA.
It is likely the single most common secondary cause. The numbers are huge. It affects maybe 15 to 30% of adult men, 10 to 15% of women. And if you look just at people who already have hypertension, over 30% of them also have OSA.
And the link here, again, often goes back to those primary factors. It's closely tied to being overweight. But the direct mechanism is that sympathetic system activation from intermittent hypoxia.
That's the key. When you stop breathing over and over all night, your oxygen levels plummet, your body panics. It sends out this huge surge of adrenaline to wake you up and force you to breathe.
And that nightly surge just jacks up your baseline blood pressure over time.
Exactly. It leads to that resistant hypertension.
The signs are the classic ones: loud snoring, somebody seeing you stop breathing, being sleepy during the day. Treatment obviously has to include weight loss. But here's something I found counterintuitive. Even CPAP, the direct treatment for OSA, only has a limited effect on lowering blood pressure. Why is that? If you fix the cause, why doesn't it fix the BP?
That's a great question. It really highlights the challenge of chronic damage. While CPAP fixes the oxygen issue, years of that chronic sympathetic activation may have already led to irreversible remodeling of the blood vessel.
So the damage is already done.
In some ways, yes. So CPAP is still essential for breathing and heart health, but you usually still need medication to manage the hypertension itself.
That makes sense. Okay, so that brings us to part 3. The other secondary causes that need careful screening. And we have to start with the one that's often right under our noses: medications and other substances.
A meticulous medical history is it's absolutely essential here. It's so easy to overlook, but prescription drugs, over-the-counter meds, even herbals can cause new hypertension or wreck your control.
What's the biggest culprit in your view?
I would point to NSAIDs, non-steroidal anti-inflammatory drugs. Over a quarter of U.S. adults use them regularly, and it's much higher in older folks with chronic pain.
How do they raise blood pressure?
They primarily interfere with kidney function, making you retain more salt and fluid.
And the list goes on, right? Oral contraceptives, common decongestants, some antidepressants, steroids.
And don't forget non-prescription things. Large amounts of licorice, believe it or not.
St. John's wort, caffeine, and of course illicit substances like cocaine. They all can raise BP.
Okay, so let's move into the endocrine system. Primary aldosteronism. This is a pretty common secondary cause, right?
Yeah.
About 5% of cases. Yes, of the non-OSA, non-medication causes. This is where your adrenal glands are just making way too much aldosterone, a hormone that controls salt and water balance.
And it comes in 2 main flavors.
2 main forms. About 60 to 70% of the time, it's something called bilateral adrenal hyperplasia. But in 30 to 40% of cases, it's a benign, non-cancerous tumor on just one adrenal gland and adenoma.
So too much aldosterone means you hold on to salt and water, and that drives up pressure. And this is where that low potassium, the hypokalemia, can show up.
Exactly. And that can lead to things like arrhythmias, maybe atrial fibrillation. But here is the real payoff. This is the critical reason you screen for this.
Okay.
Recognizing that benign unilateral adenoma is the whole ballgame.
A potential cure for hypertension that completely changes things.
It does. For those 30 to 40% of patients, their hypertension can be cured or substantially improved with an adrenalectomy. You take out the gland, making the extra hormone, and the blood pressure can completely resolve or get dramatically better.
Wow. From lifelong medication to a potential surgical cure.
It's a total shift in strategy.
That is fantastic. Okay, the other big category where a cure is possible is renovascular hypertension. Basically, a plumbing problem in the arteries going to the kidneys.
Right. It only accounts for about 1% of all hypertension, but you have to distinguish the cause.
And the vast majority, 90%, is due to atherosclerosis, hardening of the arteries, usually in older patients.
And here's the crucial finding for that group. The big clinical trials have failed to show any special benefit for putting in a stent or doing surgery compared to just good medical care.
So for the 90%, it's still about medications, specifically those RAAS blockers.
Correct. Drugs like ACE inhibitors and ARBs, they are critical because they counteract the signals the kidney is sending out because it thinks it isn't getting enough blood flow.
But there's a minority group that behaves completely differently.
And that's the high-yield diagnosis, fibromuscular disease, or FMD. This usually affects younger patients, mostly white women. Instead of a single blockage, the artery has this classic string of beads or sawtooth look on an X-ray.
And because the cause isn't just plaque, the treatment is totally different.
Exactly. This is why you have to look. For this specific group, angioplasty, just ballooning the artery open, very frequently results in a cure or substantial improvement of their hypertension, a completely different outcome.
Okay, let's wrap up with a few specific contexts and rarities. First, renal parenchymal disease, or RPD. This is when the kidney tissue itself is the problem.
This is the classic chicken and egg scenario. Is the high BP the cause of the kidney disease or a consequence of it? It's often hard to tell. Most people with chronic kidney disease have hypertension, and it's often very hard to treat.
Right, they often need 3 or more drugs. But there's some exciting new evidence here.
There is. Traditionally, we thought certain diuretics wouldn't work in advanced kidney disease, but recent studies show that a long-acting one, chlorthalidone, can cause substantial BP reduction even in patients with advanced kidney failure.
That's a big deal.
It's changing practice.
Okay, switching gears completely. Hypertensive disorders of pregnancy, HDP. This affects more than 10% of pregnancies.
And about 3 to 5% are complicated by preeclampsia.
The critical takeaway here is about drug safety. You have to avoid ACE inhibitors and ARBs because they can cause birth defects.
Absolutely. So the first line recommended safe treatments are labetalol, nifedipine, or methyldopa.
Finally, let's just quickly run through the really rare diagnoses. Cushing's syndrome.
Right, excessive cortisol. Over 75% of these patients have hypertension. And you look for those classic visual signs, the moon face, the buffalo hump on the back, and purple stretch marks.
Then pheochromocytoma. Very rare tumor pumping out adrenaline.
The key here is paroxysmal attacks in younger patients. These sudden, severe episodes of super high BP, drenching sweats, explosive headaches, and heart arrhythmias.
And lastly, the congenital one. Coarctation of the aorta, a narrowing of the main artery that you're born with.
And the classic physical sign is you check the pulses. They'll be strong in the arms, but weak and delayed in the legs and the femoral arteries.